Welcome to the Syneos Health Podcast, Conversations on Commercialization. I'm Tyler Cowan, Vice President Commercial at Syneos Health. In this series, my co-hosts and I are having discussions on how biopharma leaders are rewriting the commercial playbook and what it takes to succeed as commercialization takes on a more strategic role earlier in product lifecycle. We're sharing cross-functional perspectives on the decisions shaping commercialization today, from value and access to evidence, stakeholder strategy, and engagement planning. Enjoy this episode. We're glad you're here.
I'm Chris Van Denberg from Syneos Health and your host for this episode of the Syneos Health Podcast, Conversations on Commercialization. We're recording from the floor of Assembia 2026 Summit, where the industry gathers to discuss the future of specialty pharmacy, prescription access, and patient care. Today, I am joined by Dale Lippert, Executive Director, CAR-T Patient Support and Services. We're going to talk about the operating models behind CAR-T patient support, specifically the trade-offs between an outside hub model and an internal hub and spoke approach, and the key design considerations for supporting patients with relapsed refractory acute lymphoblastic leukemia. Dale, it's good to see you here.
Thank you, Chris. I'm glad to be here to be able to share some of my experience with you all. Thanks for having me. I lead the CAR-T Patient Support Services, so my world sits at the intersection of access, site experience, and the operational reality of vein-to-vein execution. I'm excited to share what may work, what may break, and the practical choices ops leaders can do to reduce cycle time and noise. As you guys know, or probably know, in CAR-T patient support isn't just a call center or a help center. It's the operating system that keeps time-sensitive, high-risk clinical and manufacturing journey on task. One missed handoff, benefits verification, apheresis scheduling, product tracking, post-infusion monitoring can turn into delays or site frustration and a significant patient impact. Today, I want to focus on two levers that matter most: how you organize your hub model that coordinates the patient journey. And then the second thing that I'd like to talk about is the design choices that make a program work for relapse refractory acute lymphoblastic leukemia, where time and clinical acuity are unforgiving. I would like to provide maybe some context and some definitions. Before I get into this, I have experienced a true hub for two CAR-Ts that I launched, and then here recently I launched another CAR-T by using an internal hub and spoke model. So I'll be able to reference some of those experiences. First, a hub model is a central team coordinating access, reimbursement support, scheduling support, education, logistics touchpoint, and stakeholder communication. And then when we refer to spokes, is really the field-facing roles and or functional teams closer to the sites, the treatment centers, the patients, the regional payers, often including reimbursement managers, nurse educators, field clinical teams, all the case managers, all those people that really are interfacing with that ATC and that patient. And then you got your outside hub model, which is really a vendor or partner model that operates all or part of the hub functions, manages the benefits, prior authorization support, logistics coordination, patient education, and also under very tight defined SLAs. And then you got your internal hub and spoke model. The manufacturer builds, operates the hub, and fills the spokes in-house with vendors using selectively for defined tasks. Both models still require a very strong governance, quality oversight, and tight integrations with manufacturing, quality pharmacovigilance, and medical affairs.
Hearing all that, which
Yes.
makes total sense. I mean, I'm glad it's so comprehensive.
Yep.
The right model depends, I would think, on what you're optimizing for.
That's exactly right. What I'm going to get into is really some points to consider in these different types of models. And I think what you'll find is somewhere in between is probably the right model. But we'll go into a little bit of detail. The right model depends upon what you're optimizing for. To your point, Chris, speed to launch, scalability, control of patient experience, and data visibility and risk management. Things to consider, or dimensions that really matter, is really speed to stand up and staffing, recruiting, training, coverage hours, multilingual needs. Then you got to think about quality and compliance, SOP maturity, audit readiness, call documentation, adverse event, intake routing, privacy controls, and then integration, connectivity between the manufacturing status, vein-to-vein tracking, site scheduling, and case status dashboards. Other thing is consistency of patient and site experience. Flexibility is really important. The ability to change processes quickly as label, payer policy, or capacity constraints change. As we know in this market, that happens frequently. And data visibility, very important to be able to manage processes, be able to manage cycle times, abandonment, denial reasons, bottlenecks, as well as your satisfaction in your processes. Of course, cost profile, fixed versus variable cost, growth phases, vendor management, and then business continuity is extremely important.
Tell me more about the outside hub model then.
The outside hub model is really that tight loop feedback, slower learning cycle between sites, hub and manufacturing unless governing is strong. Variability, risk, turnover, and uneven expertise can show up inconsistent site experience. Escalation clarity, must hardwire all clinical questions, AE reports, temperature excursions, change identity issues, data tooling, SLA traps, as well as patient privacy and consent, confirming consent capture and permissible use of boundaries.
That all sounds like things to watch out for.
That's right.
And what happens with an outside hub model still? When does it work well?
What works well is that you have the ability to have a fast launch and establish the infrastructure, hiring pipelines, and training capabilities. You're also able to scale coverage. I mean, when you have an outside model, you can communicate and indicate to them that you want to scale down, scale up, and you will have the ability to do that. Also, process maturity. They have the experience. They have all the resources available to them. And then also operational resilience. They got that built-in redundancy that they're able to provide. The first 2 CAR-Ts that I launched, I was under this model, and it really worked well. However, I only had 3 months to get ready for launch. So we had to go outside to be able to get that expertise.
And now Autolus is internal?
Autolus is internal hub with a spoke model, which is completely different. Let me tell you.
Yeah.
Control of experience and standards is probably the biggest key, is tighter control of training, scripts, consistent case management quality. You also have the ability to be flexible, have the ability to be nimble, and be able to change pretty quickly. When you're an outside model, that's sometimes a little difficult because you have to go through all the contracts and everything to go through it. Also, faster cross-functional problem solving. You have internal relationships that you're able to work through and be able to come to some resolution very quickly with your partners, your manufacturing ops, your quality, and your commercial and medical teams. Deeper disease and therapy expertise, having those in-house teams there to be able to support you with that specialized knowledge. Also, data ownership and insight, clear ability to instrument end-to-end metrics, and also it's a very strategic differentiators because the employees that are taking care of your patients and caregivers are part of the organization that you work for.
That makes a lot of sense. Now, I'm not deeply versed in hubs, nearly as much as you, of course, and my question is, when you are looking for the internal expertise to help, does that come from the medical side at all, or is that a very different group?
Oh, yeah, it really comes from the medical side. When you have an internal hub, you work very, very closely with that team. However, I'm assuming you're asking the question in regards to that internal support that would be maybe part of the hub team. The people that I focus on are those individuals that have managed cancer centers, etc. So they have that level of experience. Currently, today, I do not have any nurses on my team. However, I have practice managers that have worn many, many different hats, and they seem to fit the mold very, very well and be able to interact with patients, caregivers, but also with the ATCs.
So it sounds like the internal model can have quite a bit of continuity within it.
Yes.
There must be some things you have to look for.
The things that you have to look for really is the time to build. Hiring, training takes longer. In my situation, it took roughly 5 months to train the case managers to really get ready and prepared for launch. So that's something you'll have to look out for. Coverage and surge capacity. Build a surge plan. What are you going to do when capacity goes up? What are you going to do? Do you hire in advance? Do you have some good milestones that you need to look out for? Also, operational complexity. Look at all the different roles. Very important to have role clarity because you got a lot of different people touching the same patients, same ATC. So you want to make sure that people aren't tripping on each other and having many touch points. Also, cost. Usually in the beginning, it's very high, a fixed cost, until you're capacity goes up. So that's something you have to look out for. And then also technology debt. Do you have all the systems that you need? Typically with an outside model, you have all those systems that come with that contract. Oftentimes with the inside, you necessarily don't.
So we've been through the outside hub, the internal hub. If somebody's trying to figure out which way to go, what sort of decision guide or points would they have to go through?
Yeah, just a few points, and there's probably many others, but the things that I identified is if you need speed and variable costs, an outside hub can be the fastest path, but only with strong governance and real-time performance management. If you need tight integration and differentiation, internal hub and spoke pays off. Most organizations land on a hybrid, and that being keep clinical escalations, site relationships, management, and exception handling in-house, and outsource repeatable administrative tasks with clear boundaries. And that's what we currently have today. That's the type model we have. Rule of thumb, outsource tasks that are standardized, in-source capabilities that are strategic, high risk, and require tight cross-functional coordination, bring those in-house.
Having a hub model is one thing. Having and designing patient support for CAR-T and refractory and relapsing ALL is complex, to say the least.
It is. And the biggest point is designing patient support for CAR-T and relapsed refractory ALL. You have to be very careful because relapsed refractory ALL is a race against time. You don't have much time. And program design has to reduce friction. It's got to prevent avoidable delays. You have to support that caregiver. Oftentimes these programs forget a very important piece, and that's the caregiver through this complex and high acuity pathway. Just some key considerations, and I've got several here just to kind of highlight. One is referral and eligibility triage. Having that front end speed, making it easy for a referring oncologist to start a case, a simple referral intake, clear documentation, define a rapid eligibility triage and next best of actions, and anticipate bridging therapy coordination needs and how they affect the timing. The other piece is financial clearance, benefit verification, prior authorization, and financial navigation. A lot of these centers have those key pieces within their institution. However, programs can also have supporting benefit verification, prior auth, and financial navigation, and starts benefit verification immediately. If you don't, it'll paralyze the task and everything will stop, and that patient treatment will stop. Also prepare for complex payer policies and rapid appeals pathways, and also provide clear estimates and support for out-of-pocket exposure, such as travel and caregiver lead planning. Another piece is treatment center readiness and scheduling coordination. Work closely with these centers. You are the experts. Identify areas of opportunity and begin talking about their apheresis capacity, inpatient ICU bed availability. Oftentimes that determines the speed of treatment. Also use single source of truth for dates and status to reduce conflicting updates. Have an explicit escalation path when schedules shift, because they will. Patient status changes, manufacturing updates, and you should be able to move very, very quickly. Also manufacturing logistics visibility, vein to vein, design communications around critical milestones, have the ability to be able to watch those milestones and to be able to intercede and intersect. However, the hubs never should get ahead of the treatment plan. Always should be right behind it, but very close. Define rules for chain of identity, and then plan for variability. Set those expectations and those timelines, but don't lose sight of the patient as well as the caregiver.
Speaking of the patient and the caregiver, CAR-Ts are a different type of therapy in that there's a lot of intense monitoring. They're often dosed in a hospital, and that probably requires a lot of education, a lot of caregiver readiness. What can you tell me about that?
I'm glad you bring that up, Chris. Provide clear education on lymphodepletion, infusion expectations, and why monitoring is intensive. Set caregiver requirements and logistics early. Post-infusion monitoring and continuity of care. Make a follow-up schedule, lab visits, cadence. And the hub necessarily doesn't do that. Actually, the hub or the internal hub works very, very closely with that site of care to understand and know what those visits are. And depending upon if the patient meets eligibility requirements for patient support programs, there is careful coordination with those different type of programs. And then also equity and access consideration. Address travel distance, caregiver burden, language needs, and social determinants that can derail adherence. You almost have to have a separate program just for the language needs because there's such a variability of needs out there. And then also measurement and continuous improvement, always looking at ways and opportunities to continue to improve insights. And I'm telling you that those things change very quickly.
How so?
In regards to the treatment plan may change or the requirements may change. And you need to make sure that your programs have the level of adaptability to be able to do that and observance. And not one patient has the same experience as another patient. They're all different.
So those are a lot of considerations. Yeah. They're all necessary. You must have long checklists back at the office. But if you were to summarize the design principles,
reduce the number of handoffs because with every handoff, there potentially could be a delay of risk. Design clear ownership for each step. Parallelize work. Don't wait for perfect information to start administrative steps because that slows down and that costs time. Design for exceptions. CAR-T journeys are defined by exceptions. Build escalation pathways and scenario playbooks. Have one source of truth. A single case record status should share across hub and spokes. And then program equals people plus process and data is the best script that fails without measurement and continuous improvement.
What is that one source of truth? Is it a document? Is it ongoing meetings? Is there one authority?
Currently what we do is we obviously use data. We use our CRM system as really one source of truth where everything is fed into. However, you can never lose sight of that daily one-on-one communication with your field teams, with your ATCs, with your patient, with your caregiver. Never allow systems to replace that interaction.
And are those communications that you're talking about with all these stakeholders, is that a routine thing that you facilitate proactively?
It is a routine. The case managers actually have regular interactions with the team. Also, every afternoon, we even have a handoff meeting between logistics, because I manage logistics as well, and scheduling, and work very closely with my partner on the logistics side. So we have handoffs there just to make sure everybody's on the same page and not necessarily solely dependent upon the data that's within CRM.
So I just want to ask you a few more questions. First, what is the biggest mistake teams could make when launching a patient services program for a CAR-T specifically?
Treating it like a standard specialty hub. Not one hub is the same as another hub. CAR-T needs exception handling, tight manufacturing visibility, and site-centric coordination.
And then in terms of outside hub or internal hub, what is your default recommendation?
I think I kind of gave the answer away earlier on in the talk, but really a hybrid. Keeping those high-risk escalations and site relationships in-house. I mean, who knows relationships better than the individuals in-house? And then outsource some of those standardized admin tasks that you can have strong SLAs to guide those decision points.
Well, that makes a lot of sense. I'm a data geek, so I love metrics. And there's so many, and I assume that they're all necessary to track. Which ones really make the most difference? What matters to you when you're looking at that information?
When I'm looking at that is I'm really looking at end-to-end cycle times. Also denial and appeal outcomes. With a denial and appeal, you need to understand really what those are, what's causing those things, because that really slows down the treatment path. Also drop-off points. What are those patients dropping off? Why are they dropping off? Also time to resolution for escalations. If escalation does occur, what is that time to get resolution, or what's maybe causing that delay? And then also site satisfaction. Never lose out on that voice of the customer, it being the ATC or the patient or the caregiver.
So when you're talking about delays and what was causing delays, well, how do you prevent them to begin with?
Well, Chris, going back to the checklist you just mentioned earlier, standardized intake checklist, parallel processing, also proactive scheduling, and weekly cross-functional constraint review. Really understand what's going on with each of those patients. Also on my case management side, I also have patient rounds that I work very closely with case managers to review each patient case to see actually what's going on and to be able to escalate those situations to other stakeholders within our unit.
But what is unique about relapse refractory ALL from a support perspective?
The acuity of the patient, the sense of urgency about the patient. Days means life. caregiver burden. Can't imagine the burden that these caregivers have to go through. Oftentimes they have to leave their job to be able to take care of their loved one, and also need to coordinate rapidly across referral sources, certified centers, as well as the local oncologist.
So knowing you for a couple of months now, and then knowing Austin Fisher very well, he doesn't hire just anybody. Why are you so thorough? Why is it so important to you? It's clearly important to you.
It's very important. One is, I bring almost 40 years of nursing experience to the table. That's very important. However, I think all of us, probably if we reflect, we all have been touched by cancer some way, somehow, either in a very negative way from a treatment perspective, or maybe a positive way that there is treatment. One thing, if you remember, is manufacturing network choices and patient service design are inseparable. Patients feel the friction immediately. They know it. Also aim for a program that is fast at the front end, transparent during manufacturing, and relentless clear about who owns the next step. And for relapse refractory ALL, again, design yourself around the urgency and caregiver reality. It reduces the burden, simplifies decisions, and keeps communication very tight.
Well, Dale, I can't thank you enough for being here and taking the time to share your insights. I know our listeners are going to learn a great deal.
Wonderful. Thank you so much, Chris, and thank you for being here.
That's it for this episode of the Syneos Health Podcast, Conversations on Commercialization. Subscribe wherever you get your podcasts so you never miss an episode. If there's a topic you'd like us to explore, send us a message at podcast@syneoshealth.com. For more actionable, future-focused life science insights, visit the Insights Hub at syneoshealth.com.